Yep, thumbs up, perfect. So my talk today is on a series of studies that we conducted from a CIHR grant that I received a few years ago, evaluating the longer term cardiometabolic consequences of being born late preterm. So I will describe some of those results, but the part that I really wanted to focus on and the part that I thought might be more of interest to some of you was the fact that for this study, we used a unique combination of linked cohort and administrative health databases to conduct this research, and some of the strengths and limitations of this approach. So my objectives are to describe the impacts of late preterm birth on child growth and cardiometabolic risk, to introduce the target kids dataset, which is the cohort study that we used for this analysis, and to describe some advantages of the linked administrative data. So why late preterm birth? So 75% of all preterm births are late preterm now. This is defined as birth between 34 to 36 weeks. You can see in the chart on the left-hand side down here that late preterm is just one small group of all of the children that are born preterm. However, the extremely preterm and very preterm are relatively rare, and the vast majority of the preterm births are the late preterm births. However, most research previously has not teased these out, and often the late preterm are sometimes even excluded from research that defines preterm using a stricter definition of less than 34 weeks. We know that children who are born late preterm tend to have less severe outcomes than the children born early preterm, and this figure on the right-hand side here is showing the mortality rates among children born preterm, and we do see that, you know, for these very severe outcomes, the children born late preterm tend to have lower risk of some of the severe outcomes at birth, but the long-term outcomes are less well established. And this is really important from a population health perspective. And when we're thinking, you know, population attributable risks, because this is a large proportion of the children born late preterm. And the rates have been steadily increasing since the 1990s, partially due to medical intervention and also possibly other reasons such as older maternal age or maternal obesity. So the first thing we did was a systematic review evaluating the association between late preterm birth and cardiometabolic outcomes in children and adults. So throughout this study, I'm talking about the children being born late preterm and then their follow-up outcomes. For the systematic review, we identified 41 studies that were published since 2000. And so for most of these studies, late preterm was defined as 34 to 36 weeks, and in some studies it was 32 to 36 weeks of gestation. We used the Newcastle-Ottawa scale to assess risk of bias, and the most common sources of bias that we identified were inadequate follow-up and lack of control for confounders. You can see here that the studies came from many different countries, although most of them were Scandinavian studies. This is probably due to their great linked databases that they're able to use in those countries. And then in terms of the measurement of cardiometabolic risk outcomes, about 63% of studies were able to look at outcomes in children before the age of 18. And these aren't mutually exclusive because the studies could be in each categories, but about 60% of them were in older, in adults. And you can see the range of different outcomes that were evaluated here. So these were our results for the association with, somebody want to guess? Can I move this toolbar? Diabetes, first one. Where's the best place to put this? I might just have to move it as we go. So this is the relation between late preterm birth and diabetes. The top half of the forest plot is showing the association for children and the bottom half for in adults. And you can see there was pretty strong and consistent evidence with a summary risk ratio of 1.25, suggesting that children born late preterm did have increased risk of diabetes in both children and adults, and overall the summary risk estimate. Similar results were observed for hypertension, although the association was less clear for children, and this makes sense because there's lots of challenges with diagnosing hypertension in children. And the measurement error seems to be a lot, probably is one of the causes for the wide confidence intervals and the lack of precision for the studies of children. But overall, there is an association between being born late preterm and increased risk of hypertension, especially. And then ischemic heart disease is one of the other outcomes that has been evaluated. And this one, this is a rare outcome, especially in young adults. And most of these studies have only been able to look at young adults. And so there's perhaps some evidence of an increased risk of ischemic heart disease, although this evidence is not as strong as for the other outcomes. And then the last one that we have here is body mass index. So this is on the continuous scale, and the mean increase in body mass index. And I think this is in children. This is the Z scores, the age and sex standardized Z BMI. Sorry, where can I put this? Does it disappear? Note to self, next time I'll make sure I have a bigger header. Yeah, but so although children born late preterm, we found convincing evidence that they do have increased risk of many cardiometabolic risk conditions. They did tend to still be smaller than children who were born at full term, so suggesting a small decrease in BMI scores. And so overall, once we consider the grade in our summary of findings, we had low or very low certainty of evidence that late preterm birth was associated with increased risk of cardiometabolic outcomes, specifically hypertension and diabetes in both children and adults. So this is good news, and this is kind of what set us off on this study to understand what's been done, what's the situation here in Canada or specifically in Ontario. And so the objective for our first two studies were to evaluate whether late preterm birth or gestational age as a continuous measure or size for gestational age were associated with cardiometabolic risk outcomes, and to evaluate the association between gestational age groups and growth trajectories in children born between 2006 and 2014 and followed up to 2021. So we had our data from the Target Kids cohort, which I'll describe on the next few slides, and it has lots of rich data on child outcomes, but children in Target Kids are recruited after they're born. We have self-report of their gestational age and some pregnancy exposure variables, but that's based on parent report. So we have our Target Kids data set linked at ICS. So this was a nice opportunity to be able to use some of the rich ICS health administrative data that we have, including the data from Born Ontario that collects the data on all of the births in Ontario to look at pregnancy-related characteristics, and then to look at child health outcomes that generally would not be captured in administrative data. For those of you who don't work with administrative data, one of the gaps that I always find with administrative data is that we don't have common cardiometabolic risk measures or growth measures. Body mass index is not something that's routinely captured in administrative data in Ontario, and other things like that. So we really needed to merge these two data sets in order to accomplish these objectives. So this was a retrospective cohort study, or a series of retrospective cohort studies using the linked data. So children were born between April 1st, 2006 and 2019, and they were participating in the Target Kids Research Network. And then we were able to link them to the ICES data and to the mom-baby data that's derived from CHEPA variables to link moms and babies in the administrative data sets. There was a series of exclusion criteria, including our standard Target Kids exclusion criteria, which includes children born very preterm or less than 32 weeks, as well as health conditions affecting growth or severe chronic conditions, and families who are not English speaking and unable to complete English questionnaires, as well as the ICES exclusion criteria, which would be an invalid ISIS linkage number, and people who are not OHIP eligible. So as I mentioned, Target Kids is a primary care practice-based research network, so slightly different than a traditional cohort study. It's an open cohort, and children can enter the study at any time up to age 6. So children who are visiting primary care, pediatric, or family practice offices around the Toronto area are recruited. I think today we have 10 or 12 different practices involved in the Target Kids Clinic. And children are recruited at their well child visits and then followed up approximately annually. But as you can imagine, this is a little bit messier than a traditional cohort study where people are followed up starting at a certain time and have scheduled follow-up visits. So it results in a lot of variations in the data collection times. There's over 11,000 children, or I think it's up to 12,000 now, that have been recruited since 2008. We have detailed nutrition and health questionnaire data as well as physical measures. So the physical measures include the standardized measurements of height and weight by research assistants and waist circumference as well. And also children are given the opportunity to provide blood samples if they choose to, but not everyone chooses to. This is led by Drs. Catherine Birkin and Jonathan McGuire at SickKids and Unity Health. So this describes just the overall goals of the Target Kids Network, which are to maximize the value of children's data through linkage across sectors, to learn about children's health and well-being as they grow and develop, to implement new knowledge to help all children reach their full potential, and to build a state-of-the-art child cohort through a primary care practice-based network. And one of the unique strengths of Target Kids is that we also conduct embedded trials within the network as well. This slide just represents a range of the different areas of research that we're interested in Target Kids, including the childhood obesity and growth. There's several other folks in the room that can speak to some of the other areas, including Catherine Koss does a lot of the work with the mental health in the Target Kids cohort. But this data are all available. They're linked at ICS. We are happy to have people use them at any time. So for our first study, we were interested in the association between gestational age and gestational size in relation to cardiometabolic risk. So first, we used data from the ICS mom, baby, and born data sets to define preterm birth as less than 34 weeks, 34 to 36 weeks, 37 to 38. So that's the early term, and then full term as greater than 39 weeks as our reference category. And our outcome measure was a summary measure of cardiometabolic risk. This was a Z-score measure combined of waist circumference, triglycerides, glucose, systolic blood pressure, and HDL, cholesterol. And this measure we've widely used in Target Kids, and I've been thinking about this for, I don't know, over 10 years now that we've been working on this, and we've done lots of systematic reviews and lots of different validation studies looking at adding in additional measures and how we should best capture cardiometabolic risk. And one of the limitations we have is that there's not really a hard outcome to evaluate this against, is always something that's challenging. And what does cardiometabolic risk look like in children? And we think of it as a preclinical measure or an intermediate marker. How exactly would we define that? But one of the things that was really exciting last year is this nice paper came out by Jacobs et al. In the New England Journal of Medicine, and they were looking at associations between cardiovascular risk factors in children and how that related in adults up to 35 years of age. And they used an incredibly similar measure of 5 cardiovascular risk factors. They had BMI instead of waist circumference, but systolic blood pressure, total cholesterol, triglycerides, and then youth smoking, which was something that's not relevant in our Target Kids cohort of young children. But they did find that this measure was strongly predictive of adult cardiovascular disease outcomes in young adults. So that's kind of exciting to see, and to at least know that maybe we're on the right track, that hopefully the summary measure of cardiometabolic risk that we use in children is hopefully in adulthood. So these are some of the characteristics of the study participants. We ended up with a total, so started off with our large Target Kids sample of over 10,000 children, linked them at ICS. And then by the time we started limiting the data set based on restrictions based on the availability of the born data and other data sets, we ended up, and who had given blood samples, we ended up with a total of 1,742 children that were available for this particular analysis. So already one of the limitations of the linked data was the fact that, we rapidly saw that many of our children, we were unable to use the full sample. And about 8.3% were late preterm. This is higher than we would possibly expect. This is for the late preterm only, so the prevalence of late preterm is quite high in our target kids cohort. And we don't have all the preterm children, the early preterm children in this study based on exclusion criteria. So this is something that's quite interesting and something we need to understand a bit further, whether that's related to a selection issue or whether or not there's differences in the population that they come from. And the mean age was 5.6 years. And we did find that children born late preterm were more likely to be male. They were likely to be from lower family income, more likely to have older mothers of non-European ethnicity, and more likely to have been exposed to gestational diabetes or gestational hypertension during pregnancy. And then we did find that late and moderate preterm birth were both strongly associated with higher mean overall cardiometabolic risk. We can see that here. And this persisted after adjustment for a wide range of potential other risk factors that might be related to cardiometabolic risk, including maternal BMI and maternal cardiometabolic events as well. And so for each additional week of gestational age was associated with a 0.06 unit decrease lower in our cardiometabolic risk score. Several of the individual components were also strongly associated with cardiometabolic risk. So not really surprising after the results of our systematic review, but it was really nice to see that this was similar in our results here in Ontario. And I think, this is a really important finding when we're talking about cardiometabolic risk factors in young adults. People aren't often thinking about things such as preterm birth or asking people about their history of, early life experiences when they're conducting any sort of screening for cardiovascular risk events. So I think this just emphasizes the importance of, at least in my opinion, the importance of early life and thinking about that. And this is the results here when we were looking at small and large for gestational age compared to appropriate for gestational age. And we found the results were slightly less consistent for this, although some of the components were associated. So small gestational age was associated with higher systolic blood pressure and smaller waist circumference. And large gestational age was associated with lower triglyceride levels and larger waist circumference. So our second outcome that we were interested in, and this was in a second paper, was looking at growth trajectories. We were really interested. There's a lot of literature on how children who are born preterm may grow differently than children who are born at term. And understanding these growth trajectories was something that was really quite of interest. So we were able to use the data, the repeated measures of child growth from target kids, and then again, using the early life data on preterm birth and other exposures during pregnancy from the administrative data sets at ICS. So using piecewise linear mixed models, and the knots were determined visually using a Loess curve, as well as based on some of the evidence from many of the other large pregnancy and birth cohorts around the world. There's a nice paper published by some of the folks at Allspac and using some of the different cohorts to look at, where they would expect when you're modeling growth trajectories, where you would expect the knots to be. And so based on that, our results were quite similar in that 3, 12, and 18 months seem to be kind of the important points for change in growth. So in total for this study, we ended up having 4,423 children that were included, and we had a mean number of 11 growth measures per child. So that was really great to see. The average follow-up time was 6 years, and similar to in the smaller cohort where the children had given blood for the cardiometabolic risk measures, we saw very similar characteristics associated with their likelihood of being born late preterm. Now, these are challenging to see, and it's even challenging when you're able to look right up at them. The manuscript for this is published, and we have all the numbers in the manuscript too, if you're more of a numbers person instead of a graphs person. But you can see here there are some small differences in growth for children born preterm compared to term, although for the most part, they're really not, I mean, I'm not sure how strong these associations are. I'm showing here each of the 4 categories of gestational age, and then over here, each graph separated shows a separate gestational age stratified by child sex. You see some kind of important differences in the earlier moderate preterm birth by child sex, and that females tended to grow faster in later childhood than the boys. And a few small differences emerging maybe as the children are getting older here, but for the most part, not particularly strong differences, I would say. And then this is for the height trajectories. And I should say, so for both these weight and height trajectories, these are the crude data, not the age and sex adjusted or not using the WHO standards, because the WHO standards are not designed for children who are born preterm, and we didn't want to adjust away the effect of being born preterm. So this is the unadjusted for preterm so that we could actually see what the difference would be. So I imagine if you did the age corrected adjustment, a lot of these differences would completely be attenuated. So in summary, late preterm birth was associated with a slower rate of weight gain after 84 months and maybe a slightly faster rate of height gain in the first year of life compared to full-term birth. But I mean, I would say longer follow-up is needed. And for the most part, I would suggest that our data don't support that the differences in growth are the main reason for the cardiometabolic risk outcomes that we see. So then we have all this data linked at ICS, and at the same time we're doing studies using just the target kids data alone and exploring some different things. And one of the opportunities that we had was then to start thinking about validation. How can we learn from the linked administrative data to improve our target kids data set and to go back to our target kids data with improved measures? So one of my students, Alexandra, did a really terrific MPH thesis here at Mac on the validation of parent-reported gestational age categories for children less than 6 years of age. So we were able to use the parent-reported data from Target Kids, which comes up to 6 years after the child was born, because it's from the first visit that they have in Target Kids. So some of them it'll have been within 1 year, but some of them up to 6 years, and asking them to recall in categories how the gestational age of their children, and then comparing this to the administrative data. And so overall, there was actually very high agreement. So we had nearly 5,000 children included in this validation study, and overall 97% of parent-reported gestational age categories matched the administrative data records. This was a lot better than I was expecting. I was really impressed with this. And I'm somebody who's done a lot of nutritional epidemiology and physical activity validation studies, and we never get anything that's anywhere near. So this really amazed me. The sensitivity and specificity for each category of term versus late preterm and moderately preterm all were quite high, and definitely all above 80%. And then when we look at the agreement and the disagreement here, so the green would be agreement in the categories. And so for the late preterm, like this would be the direction of the misreporting. So maybe parents who had a child who was born late preterm were more likely to report their child as being born term. But part of the reason why we did this study was we thought we could use the validation study results for future epidemiologic studies where we were doing quantitative bias analysis. The reviewers of papers always have concerns with self-reported outcomes, right? Especially when self-reported recall, that's something that flags concern. And so we did lots of subgroup analysis in this paper that's published as a validation study in epidemiology, and to look at whether there were really any strong consistencies and differences of the parents who had better recall of their child's gestational age or not. And for the most part, I would say it was pretty good all around. So this was, kind of, I think maybe one of the least of our worries when we're looking at using observational research data. yeah, so overall there was high accuracy, and so good news story that the differences were really, really quite minimal. The results could potentially be used for quantitative bias analysis of future studies, but I mean, I would suggest if we're going down the path of doing bias analysis, I think I'll be looking more at selection bias and confounding and things perhaps other than this particular source of measurement error. Okay, so then the last study that I have to talk about, just a few minutes, so was, okay, so we did the few studies using the linked target kids and ICS data, and then we thought, well, what can we do just with the ICS data alone? There's tons of people doing all of these great research studies with ICS, but when it comes to life course studies, there's not too much out there. So we wanted to know, well, how far back can we go in the ICS data to actually look at, the children who were born late preterm and start to develop a cohort to follow them forward in time. So when we submitted this grant, we had all of the necessary consultation with ICS. We had what we thought was, the best information at hand. And we thought we were going to be able to look at the association between gestational age and diabetes, hypertension, and ischemic heart disease in young adults. So whether you were born preterm, and then the outcomes in yourself when you follow up. So not the mother's outcomes. However, one of the very first challenges we had is we couldn't go back as far as we thought we could. And then it turned out there was no data on gestational age available. So we had to change our primary exposure for the early years so before 2012, there was unfortunately no data on gestational age. So we ended up doing this study on birth weight. There's so many different things that cause birth weight that, it's perhaps not the best exposure variable, but it was still, I think, an interesting study. And I'm glad that we were able to do it. But this was young adults from singleton birth that occurred from 1994 to 2002. We thought we'd be able to go back a bit further than that, but by the time we incorporate a look back period and all the different logistics and what data were actually valid, 1994 was as far back as we could go. And then, as I mentioned, so gestational age was not available, so we ended up having to use birth weight as our primary exposure variable. And then our cardiometabolic outcomes were adult onset diagnosis of diabetes, hypertension, or ischemic heart disease. These were using validated algorithms where they were available in the ICS data set, and we were able to look at outcomes from age 18 to 26 years. So this ended up being a relatively narrow range, and especially for conditions like ischemic heart disease, you would expect it to be relatively rare in that age group. And so, but we did have a large population-based sample size of nearly 900,000 study participants. So one of the strengths was a great big sample size. And we did find that, children who were born low birth weight, so less than 2,500 grams, and we expected to see some U-shaped associations or reverse J-shaped associations for some of these outcomes. So that's why we modeled this categorically with the three categories. So for children born less than 2,500 grams, yes, we see very strong associations for increased risk of diabetes in both the adjusted and the unadjusted models, suggesting that being born low birth weight is associated with increased risk of diabetes. And I should say here, we can't tease out whether this is type 1 or type 2 diabetes, so another limitation of this data. Then maybe a small, modest increased risk for the children that are born large birth weight as well. Yep. Yep.
It's diabetes attained from 8. So if they receive the diagnosis prior to age 18, are they tested or no?
So that's a good question. So for diabetes, in theory, so we excluded them if they were diagnosed before, but the validity of the capture before age 18, I think, is questionable.
Is that why you excluded them?
And it was also because we were specifically interested in the adult health outcomes in this study, and we expected that some of the child diabetes would probably be the type 1 diabetes, right? Yeah. Hopefully after age 18, most of it's probably type 2 diabetes, but yeah, all of these are assumptions. We're not totally sure. And then hypertension gets trickier because hypertension, there just is no data on less than 20. So we were unable to exclude anyone who had a diagnosis of hypertension before age 20. And the validated algorithms just capture people over age 20. So again, a smaller sample size and, definitely some messiness in the data here. But we do see that low birth weight was associated with increased risk of hypertension. And we don't see that being born bigger was associated with any added risk. If anything, it was protected. So this was more of a linear association between birth weight and hypertension. And then lastly, for ischemic heart disease, this outcome was quite rare, as you would expect. And the confidence intervals you can see here are quite wide. So we can't say much with any certainty, but we do see a potential increased association between being born small birth weight versus average birth weight. And we don't see an increased risk for the large birth weight children. So in summary, we found that late preterm birth was strongly associated with cardiometabolic risk during childhood. The part of the story here that I wasn't able to tell and that I was quite excited about, and what we also had written in the grant, was to explore some of the reasons why late preterm birth might be associated with cardiometabolic risk. We really wanted to understand, the treatments that people receive during pregnancy, steroid treatments and things, and to understand if there was differences. Even some of the work, I think we were able to stratify by mode of delivery, but many of the other variables that we were interested in, there just wasn't sufficient amount of data available. And so we definitely ran into the problems with the limitations of the data. We wanted to look at differences by breastfeeding status, and for various reasons, we were unable to do all of that completely. No, I don't think so. Well, I mean, so parents might report their date of first menstrual period or something, last menstrual period, for us to calculate it. But wherever possible, it's based on ultrasound in first trimester that they date the date of pregnancy onset. Yeah, it would be captured from administrative data. So whatever was recorded in the administrative data claims. You're right, then some of it does come from. Yeah, no, I mean, I don't think it's directly parent reported in the administrative data records. It would be based on. Anne's shaking her head. You know the answer to this better. Yeah.
And most moms do have an early dating ultrasound, so most of the time it would be an objective. I trumped the ultrasound, but yeah.
And then I mean, I think it was a nice having the two data sets that we were able to do the validation study, and for future, I can see that could be really valuable for other exposure and outcome data, where we could then apply the results from the validation study to the to try and correct or improve our observational research data. So in conclusion, I would say there were several strengths of the study. It was a really neat opportunity. I felt like every day I was learning something new as we were going through this. And there's so many experts in using all these administrative data sets, and it sounded like it was going to be easy to do. But as you kind of get in there and start working with the data, and luckily I had a lot of experience already with the target kids data set, so I knew the limitations of that data set and the strengths. And then when we started linking it to the ICES data, understand what was there and what wasn't there, and a huge amount of help and support from our colleagues at the ICES McMaster site, as well as Dr. Hilary Brown from U of T was our supervising ICES scientist on the project, so he was incredibly helpful. So overall, I think the end of my story is just that this was a great opportunity, and I think there's huge potential for future linked cohort and administrative data studies. Lots of neat things that we can do, and this was just a start, I hope. And thank you so much. I want to acknowledge my team members, including Yulika, Yoshida, and Montezuma, who did the analysis for the first two late preterm papers, and Alexandra, who did the validation study. Dr. Hilary Brown, Charles, Jonathan, and Catherine from the Target Kids team. and funding from CIHR for this work.